Good morning, everyone. I am Dr. Abhyarthna from the Department of Dermatology, and today we have gathered here to discuss a case of multiple necrotic ulcers with fever in an adult male, a diagnostic and therapeutic dilemma. A 37-year-old male hailing from Muzaffarnagar, Uttar Pradesh, laborer by occupation, presented to the AIIMS Rishikesh Dermatology OPD in January 2025 and was admitted twice, initially in January and subsequently in June 2025. The patient came with the chief complaints of multiple red, raised, painful lesions and raw areas with pus discharge on different parts of the body since last 12 days, associated with high-grade fever. The patient was apparently asymptomatic 12 days back when he started developing multiple episodes of red, raised, painful lesions that were abrupt in onset, started from the bilateral upper limb, and rapidly progressed to involve the bilateral lower limb, chest, abdomen, and back in a span of 4 to 5 days. These lesions subsequently developed pus within them that ruptured spontaneously in the next 3 to 4 days to leave behind painful raw areas with pus discharge. As for the fever, it was intermittent in nature, high grade, associated with chills and rigors, and resolved on taking oral medications. There was no history of any light or red color lesions over the body. There was no history of any sore throat, any GI disturbances, or recurrent genital and oral ulcers. Similarly, there was no history of joint pain, burning micturition, or any drug intake prior to the onset of the lesions, or history of IV drug abuse, high-risk behavior, and blood transfusion was also absent. There was no history of any ocular or nasal complaints or scrotal tenderness. There was no history of any facial edema or edema of the extremities and sudden weakness of the extremities. There was no history of any unnoticed trauma leading to spontaneous dilatation or slippage of footwear or difficulty in any fine movements. In the treatment history, the patient visited a local practitioner for the complaints where he was given some oral medications for 5 days with minimal improvement. Subsequently, due to the persisting symptoms, he presented to the AIIMS Rishikesh Dermatology OPD. There was no significant past medical or surgical history. The patient is married with 4 children, has a low socioeconomic status, consumes mixed diet, has normal bladder and bowel habits, and no addictions. However, he complained of interrupted sleep since the onset of the symptoms. There was no significant family history. To summarize, a 37-year-old male presented with the complaints of widespread development of red, raised, painful lesions along with formation of painful raw areas with pus discharge since last 12 days associated with intermittent episodes of high-grade fever.
Okay. So, short history, young male, acute onset symptoms, possibly 2 weeks history of skin lesions followed by development of fever. So, can we have any residents for the differential? Anyone from medicine? Any medicine here? Okay. Anyone from dermatology? Junior residents, dermatology? Yeah, please come to the dais and introduce yourself and make comments. So this must be a very common problem you must be seeing in dermatology. So I'll request you to keep common problem differentials as first.
Good morning. I am Dr. Karthik, a junior resident, Department of Dermatology. Based on the history on a young male with a sudden onset of painful lesion associated with fever, the first differential that come into my mind is leprosy type 2 reaction. Other which can be because of the fever, it can also be some infective etiology like furunculosis which can present it with the ulcerated lesion. Other differential like the small vessel, the medium vessel vasculitis can also present with the painful subcutaneous nodule which can ulcerate. And also the pyoderma gangrenosum can also have this sudden onset of painful lesion which ulcerate in such a short span of time.
So of the 4 differentials which you have kept, what will be the number 1?
Sir, number 1, I would like to keep leprosy type 2 reactions.
It's so common.
Sir, if the patient says the sudden...
I'm not an expert, so I'll just make comments. You need to respond to that.
Yes, sir. In dermatology, OPD, it is quite common to see a young male with a sudden onset of painful lesion associated with episodic fever. The crops of these lesions, they are
So you say leprosy, second pyoderma gangrenosum, folliculitis,
not sir, furunculosis, which can ulcerate.
furunculosis, and fourth was vasculitis.
Yes, sir. That's
Okay,
correct.
thank you. Any other differential? Any other senior resident from dermatology would like to have a difference of opinion? Yeah. So could it be acquired immunodeficiency which is leading to some of these problems?
Good morning, everyone. I'm Dr. Shivani, Senior Resident in Dermatology. So, while as my resident, Dr. Karthik has already shed light upon the common differences. Along with this, including leprosy in reaction, there can also be elusive phenomena in leprosy, which is a type of reaction seen in untreated leprosy, which can present with cutaneous nodules which ulcerate. And along with that, considering some autoinflammatory syndromes, there can be pyoderma gangrenosum, including certain syndromes like Papa syndromes, or there can be other autoinflammatory syndromes like familial and Mediterranean fever, but they will have a longer history of relapsing fever and other inflammatory symptoms also. And in vasculitis, as he said, medium vessel vasculitis is what could be the differential in this case. And for infective causes, we could also consider papillonecrotic tuberculate reaction in a patient who has multiple ulcerated lesions.
Tuberculosis.
Yes, sir.
Okay. So apart from four differentials, just to summarize, what were two other differentials? Tuberculosis and
Autoinflammatory conditions, tuberculosis and papillonecrotic tuberculosis, and elusive phenomena in leprosy.
okay. Thank you.
Thank you.
So we have now six differentials. Your comments on that?
So based on
So let's start with furunculosis.
so furunculosis can
I know the slides, ma'am, so that's why.
furunculosis can present with multiple ulcerations. However, sir, they are more present over the hair-bearing regions, and widespread involvement can occur. However, the distribution will be patchy distribution, and there will be a history of immunocompromisation or any history of diabetes will also be present. Widespread involvement is common in immunocompromised state.
Pyoderma?
Pyoderma can occur, can have widespread occurrence, and it usually begins in the lower limb, but it can have a widespread occurrence, and the lesions are similar to the presenting case.
So what are your differentials?
Based on the history, our differentials were pyoderma gangrenosum, Sweet syndrome, lepromatous leprosy with erythema novus and necroticus, lepromatous leprosy with Lucia phenomenon, medium vessel vasculitis, and secondary syphilis, that is the Louis maligna variants.
Oh, good. Please go.
It is Sweet syndrome. So, Sweet syndrome is also neutrophilic dermatosis, presenting with painful nodules and plaques and pseudovesicles, along more commonly in the upper trunk region. However, in severe cases, ulcerations are also common associated with fever.
Is it associated with underlying leukemia kind of situation?
No, sir.
What is the etiology?
Etiology, it can be idiopathic, and along with that, it can be due to autoimmune disorder, associated with autoimmune disorder, and drug intakes can also be present. Underlying malignancy can also be present, sir, but it is less common, sir.
So, in next slides, you are talking about points in favor, points against these.
No, sir, not.
Okay, so let's discuss because so you say pyoderma is possible,
Yes,
Sweet syndrome is possible,
yes.
leprosy.
Leprosy is a common presentation, sir.
Okay, so syphilis. Do you really see syphilis nowadays? Your comments on this?
Sir, syphilis is seen commonly. Sir, but the Louis maligna variant is a rare variant.
What is this?
Sir, it is a malignant variant, not neoplastic, but severe variant that presents with sudden onset of multiple tender nodules and papules leading to ulcerations, and it is a type of secondary syphilis. Sir.
Okay. So, in a year, how many cases you see of syphilis in dermatology?
Sir, in the OPD basis, sir, it is not very common, but however, monthly we see approximately 2 to 3 cases are seen, sir.
Okay. Please carry on.
Following this, general physical examination was done. The patient was conscious and oriented, and the vitals were stable at the time of admission with a temperature of 101.2 degree Fahrenheit. There was no pallor, icterus, cyanosis, clubbing, or pedal edema. However, bilateral inguinal lymph nodes were palpable and tender. All the systemic examination was within normal limit. In the mucocutaneous examination, as seen in the image, the initial lesions were well defined, erythematous, tender nodules and plaques that gradually evolved to form central pustules, following which they ruptured spontaneously to form well-defined, irregular shaped, punched out ulcers with peripheral erythema. Multiple well to ill-defined erythematous tender nodules of size ranging from 0.5 into 0.5 cm to 2 into 2 cm were present on the bilateral extremities. Similarly, as appreciated in the images here, multiple well-defined round to oval-shaped punched out ulcers with yellowish slough on the base and overlying hemorrhagic crusting over few of the lesions were present on the bilateral extremities. And associated with this, bilateral ear infiltration was also appreciated. All the other examination of palms and sole, scalp, nails, and all the mucosal examination was within normal limit. What's the age of this patient? From 37 years.
Can you go back to previous?
Yes.
Will you use next one? So when you say palms and soles not involved, mucosa not involved, nails not involved, so does it have some connotation in terms of establishing a diagnosis or?
Yes, sir. For example, say palms and soles are commonly involved in the secondary syphilis.
Okay.
Diagnosis of secondary syphilis. Mucosal involvement can be present in, autoinflammatory disorders can also be present, sir. And in early other infectious cause, it can be present, sir. And nails examination we do, for example, if Bu's lights are present, they show the chronicity of the underlying disease, sir. Growth arrest is seen from that, sir.
And scalp and hair?
So scalp and hair involvement, if any erosions or ulceration are present in the scalp regions.
Okay, carry on.
Additionally, sensory examination was done for testing the hot and cold sensation. 2 test tubes filled with hot and cold water at a temperature of 45 degrees Celsius and 25 degrees Celsius are used, and it was seen that there was complete loss of differentiation of hot and cold sensation on the bilateral upper limb up to the mid forearm area, and in the bilateral shin up to the mid shin, bilateral lower limb up to the mid shin region. Additionally, sensation to fine touch was also reduced by approximately 40 to 50%. In the left upper limb, it was along the ulnar nerve distribution up to the mid forearm area, and it was reduced by approximately 50 to 60% in the bilateral lower limb up to the mid shin region. On nerve palpation, bilateral ulnar nerves were grade 2 thickened. That was, it had a rope-like thickening, and while left radial cutaneous nerve and left posterior tibial nerve were grade 1 thickened. However, there was no neuritis, that is, there was no tenderness and palpation of the nerves. Following this, multiple tests were done to check the motor function. The card test and the Wattenberg sign, they test the action of the palmar interosseous muscle, and the book test, they test the action of the adductor pollicis muscle, along with Igawa test that checks the strength of the dorsal interosseous muscle. All of these tests are used to assess the function of the ulnar nerve, and these were found to be positive on the left upper limb, while the beak sign assesses the combined function of all the three nerves of the upper limb, that is the median, radial, and ulnar nerve. And this test was also found to be positive on the left upper limb. Considering the clinical examination findings of presence of infiltration and ulcerations, the primary diagnosis of lepromatous leprosy was made, and considering the presence of systemic symptoms along with ulcerations, the differential of erythema nodosum leprosum necroticus and Lucio phenomenon was considered.
So, young patient, acute history, ulcerating lesions with fever, with some neurological involvement and nerve thickenings. So, looks like leprosy, but any mimics in dermatology on similar presentations? Or there is no other differential apart from leprosy? It's open and shut case. Anyone from dermatology, junior resident, senior resident, or faculty can make a comment. So this is clinically open and shut case of leprosy. That's it? No differentials? Some of them are shaking their head no. So any resident, any differentials? You came up with this Lucio phenomena, so you're pretty sure that there is no other differential. Can vasculitis have such kind of presentation?
So in vasculitis, medium vessel vasculitis like cutaneous span can have such ulcers, but it will have other systemic features as well. There will not be any loss of sensations, and more commonly infiltrated plaques with loss of sensation points towards leprosy with thickened nerves. So hence the diagnosis was not doubtful in this because he went to leprosy only.
So if you get 100 cases of such presentation, 100% will be leprosy.
So if a patient comes with only ulcers, of course there will be differentials.
There's such presentation. Now we have history, we have examination. I keep 100 patients, give you 100 patients to you. At the end of the day, all 100 will be having leprosy?
So yes, I would like to keep leprosy and investigate and confirm my diagnosis with biopsy and slit skins. But with such presentations, I would keep leprosy only.
Thank you.
Thank you.
Any faculty would like to make comments?
So with the clinical presentation along with the examination findings, there are three cardinal signs of leprosy. One is the hypopigmented or hypoaesthetic, that is anesthetic patch, along with nerve thickening or neuritis, and the third is slit skin smear positivity. So if either of them is present, we go towards leprosy only. So a case who has skin lesion, maybe not hypoaesthetic patch per se, but he does have a diffuse sensory loss in bilateral upper limbs and lower limbs, along with typical cutaneous lesion which point towards erythema nodosum leprosum. So we are inclined to make a diagnosis of leprosy only, investigate further. Because the other differentials that were kept, like syphilis or vasculitis, we don't have sensory loss per se. So that is one of the main features over here.
So we still haven't got investigations.
Yes.
So let's say this patient had a blood sugar of 500.
Then we can think of peripheral neuropathy.
Yes,
but
because
then we'll have to do a slit skin smear examination also, which if comes to be positive, then we have to go towards that. Plus, if the patient has diabetic neuropathy along with cutaneous ulceration, then those trophic ulcers are mostly located on the lower limbs. They are not so generalized on the body as such.
So for all practical purposes, this is leprosy.
Yes.
Any other comments? Yeah. You can take your seat now. You can take your seat.
Though diabetes does show neuropathy, nerve thickening is, I think, the clincher here, because nerve thickening will not be seen in any other differential, even in vasculitis, which might show in rare cases neuropathy, but nerve thickening will not be there. So I thought that we think that nerve thickening is a huge pointer towards leprosy.
So, Dr. Vitti, what are differential diagnoses of nerve thickening? Any apart from leprosy? No other differential?
There are differentials, so these include amyloidosis. In a
Yeah.
very rare case of amyloidosis, we might see, but these cutaneous ulcers are not seen. It will have pinch purpura, it will have infiltrated plaques and papules, which were not seen in this case. So these nodular pulstular lesions with ulceration are quite like erythema-nodosum, leprosum, or Lucio phenomenon, along with nerve thickening. So I think nerve thickening and apart from neuropathy, so both are like clincher for leprosy.
Thank you. I think they'll tell. Any other possibilities? Any other comments? Ma'am, would you like to make any comments?
No, I think the presentation is very good, but I think you should have shown some videos of those tests when you were doing sensory and leg study. You did.
Thank you. Carry on.
To clinch the diagnosis, the presence of round, deep punched out ulcers and the presence of constitutional symptoms points in favor of the diagnosis of erythema nodosum leprosum necroticans. However, this entity is not commonly present in untreated cases, and there was absence of neuritis in our patient that points against the diagnosis, while the Lucio phenomenon commonly presents in the untreated patients. Along with this, there is no neuritis in this. That points in favor of the diagnosis of Lucio phenomenon, while the point against are the presence of nodular lesions, the presence of constitutional symptoms, and the absence of ulcers with angulated margin that points against the Lucio phenomenon.
What do you mean by neuritis? What term?
Ma'am, neuritis is tenderness of the nerve on palpation, sir. When
Okay.
we palpate the nerves to check for the thickening of the nerves, if there is tenderness, that counts as neuritis, sir. Inflammation of the nerves.
So when you palpate the ulnar nerve, it would be tender.
Yes.
Okay. Carry on.
Following this, investigations were done. The diagnostic.
So, MS ma'am's question, can you go back to? So, what are these two differentials? What are we trying to say in terms of lepromatous leprosy, erythema nodosum versus Lucio phenomenon?
Ma'am,
What is pathophysiology? And
both the
yeah,
Sir, erythema nodosum leprosum is a type 2 lepra reaction, which occurs due to type 3 hypersensitivity, and it occurs due to immune complex deposition in the various organs and blood vessels of the body that leads to inflammation and favors the Th2 type of inflammation, while the Lucio phenomenon occurs due to infiltration of the bacilli within the vessel walls. Along with that, endothelial proliferation is present, which causes vascular thrombosis, leading to the ulcerations.
so Lucio is more like a vasculitis kind of phenomenon.
Not exactly vasculitis, sir. That there is the inflammatory infiltrates are less common. It is just due to the thrombosis.
Obstruction. Okay.
Thrombosis.
Carry on.
Following this, investigations were done. The diagnostic investigations included slit skin smear and histopathological examination, and the routine investigations included complete blood count, liver and kidney function test, fever profile, viral markers, and all the cultures, including the urine, blood, and pus culture. During the first admission, the patient's hemoglobin was 9.6 gram per deciliter, and the total leukocyte counts were raised, that was 19,690. In the liver function test, the liver enzymes were also mildly increased, and the prothrombin time was deranged. It was 17.6 seconds. However, all the renal function tests were within normal limit. Along with this, the viral markers were non-reactive, and all the cultures came out to be sterile, and the fever profile was also negative. Following this, a slit skin smear was done, which showed the presence of fast bacilli with the bacteriological index of 1.6 and the morphological index of less than 10%. A G6PD level was also done, which was 28.82 units of gram per hemoglobin, which was within normal limit. And the nerve conduction study was also done, which showed a reduced combined muscle action potential amplitude of the left ulnar nerve, and the sensory latencies of the bilateral ulnar and sural nerve were not recordable. Due to the recalcitrant nature of the disease, a drug sensitivity testing was done, and the tissue sample was sent to the Stanley Brown Research Lab, that is in association with the Leprosy Mission Trust of India, and the report came out to be sensitive to rifampicin, dapsone, and ofloxacillin. Now I would like to invite Dr.
So
Kash.
this is a PCR based test or culture based?
PCR based test.
Okay.
Now I would like to invite the pathology team for highlighting the histobag findings.
So just to ask you a question, you have AFB which has been demonstrated. Your nerve conduction showed neuropathy. What was the need of histopathology?
So histopathology is the confirmatory diagnosis. Along with that, sir, we considered the two differentials of erythema nodosum necroticans and the Usher phenomenon. Histopathology helps to differentiate those two entities, sir.
So the treatment difference is
Yes, sir.
differs in both these conditions?
Treatment, is different, sir. Yes.
Okay.
Had a pretty sure diagnosis of leprosy, but you did a whole lot of other investigations. Why so? Just one factor and the some tests which went to specific. Yeah. Why do you have to do all this?
Ma'am, fever profile was done for the secondary infection, to rule out any secondary infection, underlying infection.
Was there fever?
Yes, ma'am.
What can happen?
So just because this question has been raised, you have a profile of patient with ulcerations and fever. Why to get dengue and malaria in this case?
So actually, despite starting the treatment, sir, the new lesions continued to appear, and there was also persistent fever in the patient despite the starting of the
It
treatment.
will never be there, na? In malaria or dengue. Even on the radio established kind.
So probably medicine opinion was taken and they would have advised. Okay. Continue. You can take your seat here. You can sit.
Yes, good morning everyone. I'm Dr. Kashmi and I'm going to present the histopathology part of this case. So we received two specimens from the patient. The first was from the nodular lesion, and grossly we received single skin covered soft tissue piece measuring 0.6 into 0.3 into 0.2 centimeters, and it was embedded. So on microscopy, on
So
the scanner,
this second lesion was from which side?
from the ulcerated lesion.
So you have two biopsies. Can you go back, Ashwin?
Yes, sir.
So now biopsy was done in this case. Okay.
So the first biopsy, on the scanner view, we can see this is the skin biopsy, which is showing the various layers of the skin. This is the epidermis, as we can see. This part is the dermis, and this is the subcutaneous tissue or the fat. The dermis is further subdivided into the upper, mid, and deep dermis. On low power view, we can appreciate this is the epidermis, which is lined by keratinized stratified squamous epithelium, which is mildly thinned out and shows loss of red ridges. The upper dermis is showing perivascular inflammatory infiltrate. The mid dermis is also showing sheets of this inflammatory infiltrate, and it is showing some clear cytoplasm cells, which are basically the foamy histiocytes. The inflammation is continuing deep down in the lower dermis, as well as the subcutaneous fat, which is showing inflammation and also some neutrophils causing panniculitis. This is a medium-sized blood vessel. These are the fat lobules, and the inflammation is going inside or within the fat lobules. It is a kind of lobular panniculitis. So on higher power, we can appreciate the inflammatory cells and these cells, which are the foamy histiocytes, which are having clear vacuolated cytoplasm, and they are concentrated themselves around the blood vessels. This is another high power focus which is showing blood vessels along with the inflammatory cells which are comprising of these foamy macrophages, lymphocytes and few plasma cells. Fight stain highlighted multiple clusters and numerous acid-fast bacilli representing the lepra bacilli, as we can appreciate over here. These are the clusters and they are concentrated inside the foamy macrophages. So to summarize, the biopsy from the nodular lesion shows a skin biopsy showing the sheets of foamy histiocytes along with numerous lepra bacilli throughout the dermis and also extending into the subcutaneous fat causing panniculitis. These features are of lepromatous leprosy with erythema nodosum leprosum. So the second biopsy was from the necrotic lesion and
What
grossly.
is fight stain?
So fight stain is a special stain done for the lepra bacilli, and it is like the Zn stain, but it is a modified version of the Ziehl-Neelsen stain, specifically done for the Mycobacterium leprae. So this show, as we can appreciate over here, these are the magenta colored acid-fast bacilli on fight stain, which are showing Mycobacterium lepra.
How is it different from Ziehl-Neelsen?
So,
Ziehl-Neelsen also you see the magenta color
yes, sir,
bacilli.
but Ziehl-Neelsen stain is done for Mycobacterium tuberculosis, and the cell wall of both leprae and tuberculous bacilli are different. So for the fight stain, we are using lesser concentration of sulfuric acid, that is 5%, while for the Mycobacterium tuberculosis, we are using 20 to 25% of sulfuric acid. It is a more concentrated sulfuric acid we are using, while here we are using a weaker acid for representing the cell wall of the Mycobacterium leprae.
How are they morphologically very different from the PB Mycobacterium tuberculosis?
So
Shreddy and they are like.
Ma'am, basically these are clusters of leprae. They are not representing a single. These arrows, they are not showing a single bacteria. They are clusters. Basically, they are forming globi of these lepromatous leprae bacilli. And these, if we appreciate here, they are present in a clear space. And this clear space is visible to the vacuolated cytoplasm of the foamy histiocytes we get in the lepromatous leprosy, which are playing a key role in the pathogenesis of leprosy. So what these are also known as the Virchow cells or lepra cells, and they are playing a key role in lepromatous leprosy. Basically, they are accumulating the Mycobacterium leprae bacilli. However, they are not killing it, and that is the reason of the persistence of the bacilli as well as dissemination of this disease. So the second biopsy was from the necrotic lesion, and grossly we received single skin covered soft tissue paste measuring 0.6 into 0.4 into 0.3 centimeters, and it was embedded. So on the scanner view, we can appreciate here again all the layers of the skin. However, if we see here, the epidermis is thinned out. Also, there is a focal area of necrosis and ulceration, as we can appreciate. The entire dermis is showing dense inflammation, which is extending deep down into the deeper dermis as well as in between the subcutaneous fat. On low power, we can see here the stratified squamous epithelium is showing acanthosis. Basically, acanthosis is not a key feature of lepromatous leprosy. However, because of the adjacent ulceration and inflammation, it is kind of a reparative change. It is a reactive epidermal hyperplasia we can see over here. And this is the dermis, which is showing sheets of foamy histiocytes or the Virchow cells as I just described. And along with that, there is dense inflammation. This inflammation is continuing deep down into the deeper dermis as well as in between the fat lobules of the subcutaneous tissue. There is another focus showing the thinned out epidermis. Along with that, the dermis is showing dilated and congested blood vessels, and these are the foamy histiocytes, and these are the dense inflammation, which are predominantly comprising of numerous neutrophils. This is a higher magnification to show the Virchow cells, the neutrophils, and these are the blood vessels. The neutrophils are attacking the blood vessels, causing vasculitis. Again, we can see here the Virchow cells having that foamy, bubbly cytoplasm, which is clear. This focus is showing a blood vessel which is having a thickened endothelial cell wall, or basically we can see thickened blood vessel wall, and it is comprising of very bright pink amorphous fibrin-like material, and we can also appreciate neutrophils in and around the blood vessels. Basically, this blood vessel has undergone fibrinoid necrosis, and there were many such vessels in this section. 5 stain highlighted multiple clusters and globi of Mycobacterium leprae bacilli within these foamy histiocytes, as we can appreciate over here. These are the virtual cells containing the numerous Mycobacterium leprae bacilli. So to summarize, the biopsy from the necrotic lesion is showing a thinned out ulcerated epidermis along with dense neutrophilic infiltrate in the dermis, in the entire dermis, and extending deep down into the subcutaneous tissue, causing panniculitis along with fibrinoid necrosis. So these features are favoring lepromatous leprosy with erythema nodosum leprosum necroticans. So since there was a clinical differential of Lucio phenomenon, I would like to highlight the key histopathological differences between the two. So in Lucio phenomenon, the vessels show endothelial swelling, there is proliferation and thrombosis. And in the ENL necroticans, as seen in the present case, there is vasculitis along with fibrinoid necrosis. The infiltrate comprising of in the Lucio phenomenon is predominantly the foamy histiocytes. The neutrophils are very sparse or absent. And in case of ENL necroticans, there is dense neutrophilic infiltrate with leukocytoclasia. Leukocytoclasia basically means there is breakdown of these neutrophils because of increased proliferation and turnover. The bacilli in Lucio phenomenon, they are numerous and they are also packed inside the endothelial cells, causing their injury. And hence there is bacillary vasculopathy, which is leading to endothelial injury, causing the formation of thrombus and resultant ischemia and causing ischemic necrosis, because of which we see the necrotic lesions in Lucio phenomenon. While in ENL necroticans, there is presence of bacilli only restricted to the foamy macrophages. They are not present inside the endothelial cells. And basically what is happening here is immune complex vasculitis. And this immune complex is formed by the antigens of the lepra bacilli. Antibody against them, they are combining and forming the immune complex and they are depositing inside the blood vessels. After this, it causes complement activation, because of which the neutrophils accumulate, and that causes fibrinoid necrosis, and there is necrotizing panniculitis in case of ENL necroticans. This is a representative image showing the histopathology of Lucio phenomenon. Here we can appreciate these are the multiple blood vessels. So there is increased proliferation of blood vessels because of destruction of endothelial cells. There is more proliferation as well going on. And here we can see these are sheets of foamy histiocytes, and there are no neutrophils. Neutrophils are very sparse over here. And this is a blood vessel which is undergoing thrombosis, and hence causing ischemia and the necrosis that is seen in Lucio phenomenon. Thank you.
Good presentation of histopathology. Okay. Any comments on histopathology by dermatologists? Happy with the report? Okay, great. Yeah.
Like when you would ask that whether there is presence of vasculitis or not, the response was that this is not vasculitis, this is thrombosis. But there is obviously vasculitis, and that is one of the cardinal features if we go one step back.
So what I had asked.
So vasculitis is vessel changes. So it's not like an inflammatory vasculitis, say, of other disease, but there is vasculitis in this condition, which is the lepromatous leprosy with necroticans. And Lucio phenomena, maybe it is a type of, it's like a phenomenon which is occurring in an underlying case of lepromatous leprosy. So it is one step ahead, maybe, or something which is in parallel to the kind of response which is seen. And obviously the treatment will not have any difference, right? For both the things, or would you be using different agents or different anti-inflammatory kind of agents for Lucio phenomena to this present?
So, the questions are two. First is in terms of pathophysiology, can you repeat again how is Lucio phenomena different from ENL necroticans? And second is in terms of, is there a difference in treatment?
Sir, in histopathology of erythema nodosum leprosum necroticans, sir, there is vasculitis, there is immune complex deposition in the blood vessels that leads to the neutrophil.
So what forms this immune complex?
So, immune complex of antigens of the lepra bacilli and the human antibodies against those antigens.
So you will find bacilli in the vessels.
In the endothelial cells, no, sir.
And in Lucia, you will find a lot of bacilli. So I think bacillary vasculopathy is because the bacilli are getting accumulated in endothelial cells, it's causing swelling of the endothelial cells and leading to thrombosis, if I'm not mistaken.
Yes.
Okay, clear. So is there a difference in treatment?
So slight difference is present. Multi-drug therapy for leprosy is to be given in both the cases. And there is a good response to steroids in erythema nodosum leprosum, that is the first line drug. And steroids can be given in Lucia phenomenon for the acute management. However, so the second line drug for ENL is thalidomide and clofazimine. While it is not responsive, thalidomide is not responsive in Lucia phenomenon.
Okay. Get it.
As highlighted by the pathology team, the presence of acute neutrophilic lobular panicalitis with vasculitis along with fibrinoid necrosis favors the diagnosis of erythema nodosum leprosum necroticus, while the absence of endothelial cell proliferation, absence of the bacilli colonization within the vessel wall, and vascular thrombosis points against the diagnosis of Lucia phenomenon. Thus, integrating the clinical findings, the presence of nerve involvement in the form of nerve thickening, sensory loss, and motor weakness, along with the positive slit skin smear and the histopathological findings, the final diagnosis of lepromatous leprosy with erythema nodosum leprosum necroticus was made.
So, a couple of questions. I'm sorry I'm interrupting you. How do you explain EML without treatment? That was a point against. And can one patient have both the things happening simultaneously?
Sir, ENL can present, cases have been reported to present without in untreated cases as well, sir. ENL can present in untreated cases. It is present in around 30% of the cases, sir. However, it is more common in the lepromatous Lucia phenomenon, where the untreated patients present with the presentation of ulcerations.
And can a patient have both the presentations on histopathology?
Sir, it is rare, sir. I haven't seen any case.
Yeah, Dr. Naveen.
Actually, in lepromatous leprosy, either of these two reactions can occur because these two reactions are slightly different. ENL is known as type 2 reaction and Lucio phenomenon is a separate type of reaction. These two cannot present together.
Okay. Okay.
On admission, the patient was initiated on the multi-drug therapy for leprosy from 9th of January 2025, and for the treatment of the reaction, the patient was initiated on the tablet prednisolone 50 mg, which was given once daily. However, due to the inadequate response, the dose was escalated to 60 mg once daily. Simultaneously, tablet clofazimine was also added at a dose of 100 mg thrice daily, which is the second line drug for the treatment of ENL. And despite these measures, the lesions continued to appear, and hence capsule thalidomide was added initially at a dose of 400 mg, which was then tapered to the dose of 300 mg. Additionally, injection PPD was also given at a dose of 0.1 ml intradermally, which acts as an immunotherapy. And despite this, owing to the recalcitrant nature of the disease, injection dexamethasone pulse was also given at a dose of 100 mg in 5% dextrose over in total 3 days of pulse therapy was given. Additionally, tablet N-acetylcysteine was also added at a dose of 600 mg thrice daily for the hepatic involvement, and for the deranged prothrombin levels, injection vitamin K at a dose of 10 mg was given for 3 days.
So this is Montu's PPD.
Yes.
So can you explain used as immunotherapy?
Yes, sir. Immunotherapy is a recent modality used that acts by increasing the cell-mediated immunity. It increases the interferon gamma response, thus accelerating the destruction of the bacilli, and as well as it reduces the severity of the reaction.
Okay. And the past history of TB vaccination has no bearing on this. Okay. Okay.
Subsequently, the patient was discharged on the multi-drug therapy for leprosy, along with that tablet prednisolone 600 mg once daily, capsule thalidomide 100 mg thrice daily, tablet clofazimine 100 mg thrice daily, tablet indomethacin 75 mg on SOS basis, and along with this, wound care and hand and feet care was also advised. The patient was then lost to follow-up for 5 months and had stopped taking all the medications except the multi-drug therapy 3.5 months following the first admission, and the symptoms relapsed 1 month before the second admission in June 2025. All the routine investigations were done in the second admission that showed a low hemoglobin level of 5.2 gram per deciliter. To further evaluate this, further investigations were done, and the reticulocyte percentage was increased to 2.47%, and a low serum iron level of 33 microgram per deciliter was seen, and the serum ferritin level was greater than 1650 nanogram per ml. And thus, subsequently, dapsone was stopped on 12th of June 2025, suspecting a dapsone-induced hemolysis. And the patient was continued on prednisolone 50 mg and capsule thalidomide 400 mg in the divided doses. As seen here, this shows the healing of the lesions as compared to the first admission in the January 2025 to the last follow-up in July 2025. The ulcers were found to be healing, as seen over here. And the hematological life quality index of the patient also reduced from 24 at the time of first admission to 16 at the last follow-up in July 2025.
So, like in tuberculosis, we have dots where the patient comes and gets the drugs. I think leprosy is also a notifiable disease and it follows a dots-like program.
Monthly blister packs are given to the patient free of cost. Blister pack for the multi-drug therapy is given, sir.
And this is given at the center of convenience, or it given at AIMS only?
No, sir, the nearby government hospital.
We don't have anti-leprosy drugs. They have to come here. I'm really worried by this patient lost to follow.
Yeah, that's why I raised this question of how is this therapy monitored? So he was from Meerut. Muzaffarnagar. So was he getting these drugs at the center of convenience, or how was it being done?
Yes, sir. The multi-drug therapy was given from the nearby government hospital, sir.
Okay. And he stopped prednisolone and thalidomide.
Yes.
Okay. And the reason was because he had improvement in his symptoms?
No, sir. Actually, the reason was that he could not afford the medications of prednisolone, thalidomide, all the other medications.
Okay. Dr. Naveen would like to add. Followed by Dr. Swasti. Sushanti, I'm sorry.
In leprosy, basically, the therapy of leprosy, that is the multi-drug therapy strips, they are given free of cost from the center. But the other drugs like steroids and thalidomide is a relatively costly medication. These are not provided. Second, in such cases, we expect the patient to come back and follow up with us because we have to monitor steroids as well as thalidomide or other medications. However, the patient basically he was not affording, so he stopped the drug after some time. So that was the reason of the relapse.
Okay. Any comments from your side?
that is the main reason that because MVT is available free of cost. So the patient was taken from Muzaffarnagar only, the local PSC or CHC. They are registered over there and they are given the monthly blister packs for 28 days. That is to be taken for 12 months. So he was taking the MVT, it is mentioned here. But for thalidomide, it's a very costly drug and he was taking 300 mg per day. So that will be around 300 rupees per day. So along with steroids and other medications. So patients usually, many of the patients do have this problem because of the low socioeconomic status. They are not able to take thalidomide. And it's a very important drug when it comes to controlling type 2 reaction. Because this patient was not just controlled with prednisolone, he needed thalidomide. So that was, I think, the main reason why he left the treatment, because of low socioeconomic status and the high cost of medicine, and then he relapsed with the disease. And many of the leprosy patients who belong to low socioeconomic status do have this issue.
And you need both prednisolone and thalidomide, or only thalidomide could have?
Sir, per se, the treatment for type 1 and type 2, both of them starts with prednisolone only, that is steroid. But in type 2 reaction, thalidomide is needed when the reaction is very severe and not controlled with steroid, or it is a very chronic reaction or recalcitrant or recurrent. So those conditions need a treatment with thalidomide.
And just another question, if you can answer. Acute symptoms, 12 days history, no past history, nothing in this patient with so much of bacillary load.
So it is possible, that is also one reason we consider Lucio phenomena, because Lucio leprosy is something where patient is clinically very much fit according to him. He doesn't have any signs and symptoms. Similarly, lepromatous leprosy, they don't have patches as such that they can visualize and feel that I have leprosy or there is some anesthesia going on in my body. It starts very slowly, insidiously, considering the incubation is so long, from 1 to 10 years. So, almost 1/3 of cases of lepromatous leprosy can present acutely with ENL. And many of the times, patients are admitted to hospital with ENL only, which have not been taking treatment for anything.
And from where did he got this infection?
Sir, it's very difficult to analyze. Maybe from the work setup, he was a laborer, maybe working with some person.
And does family needs screening?
Yes, family was screened and they are usually given a single dose prophylaxis of rifampicin.
Okay, thank you. You want to make a comment? No, we still have.
So, number one, before we
Pardon?
go to some contentious points, I think the presentation was very good. And both the residents, dermatology as well as pathology, and their senior resident, they really were very confident and they answered their questions very well, which is, I think, quite laudable. The rest of the thing, I think, in the management was, one is this PPD which is given. Usually it reacts, when there is already some kind of microbacterial infection has occurred. I don't know what kind of immune response it will give, which will be protective to the host. But BCG has been found to be very effective. One is in preventing leprosy. This is one vaccine which has been tried for leprosy, and several meta-analyses have shown that it gives 20 to 30% protection to the contacts, like even in household contacts. It can be given, and we need to see whether the household contacts had received PCG or not. And same is true of the patient, whether he had received this vaccine. But I quite doubt, because in some of these beds in Muzaffarnagar and all, vaccination is rather poor. And he was born 35 years ago. So that is about the vaccination part, which I think we should think about. And there is a new leprosy vaccine which was approved somewhere in 2016. I wonder what is going on about with that vaccine and what is the coverage like, and especially some of these belts where leprosy is very, very prevalent. So my question was related to the follow-up actually. This MDT he was getting in the center, wherever the leprosy sample was. But I think he wasn't getting thalidomide, right? Rest of the things he was getting. But he still said he was lost to follow. Lost to follow-up means we lost him. We lost the follow-up. Because we also are responsible for following up these patients. So I would suggest that you set up a system of follow-up for your serious leprosy kind of patients where you need treatment to be continued. You can do it with the help of telemedicine. I think we must implement that because we don't want to lose patients of things like leprosy and TB because they will need therapy for a longer period. So try to set that up because we should be following up these patients. We should not lose them. They're not very far away. So that was my only concern. Otherwise, I think the way you manage the patient, the way he has recovered is certainly very laudable.
Thank you. So I think for want of time, we'll close the session because
Slide is left.
Just one discussion part.
Discussion to done.
yeah, discussion done. So I think I thank you, Department of Dermatology, and
Don't say anything.
carry on, quickly. Yeah, remember this Ridley Joplin classification. MBBS में बहुत पूछा जाता था.
ये pausing is very important. 7% from India. Okay.
Okay. Thank you all for your active participation.